Well, if Dr. Alderondo thought he had problems with his glasses, I can assure you I have more. I have 2 pairs of glasses. And neither of them had the right focal length, so I'm going to have to speak from over here. I appreciate very much the chance to talk to you about the issue of HIV/AIDS today, particularly with regard to the border region of Mexico and the United States. As you've probably guessed or detected, I have an Australian accent, but unlike Hugh Jackman, I will not be singing or dancing or even looking particularly good. What I plan to talk to you today about is HIV/AIDS in the Americas generally, and then try and focus down to Mexico, the US, and the border region. I had the privilege of updating a report for PAHO just last year, where we looked at the progress of HIV/AIDS in the Americas. So I'm going to talk a little bit about that. Then I'm going to raise some questions for you. We talk a lot about the term Hispanic, but it seems even from what we talk about today that there are various different definitions of this. And so I'm going to essentially deconstruct and hopefully reconstruct that conception so we know what we're talking about. Unfortunately, some epidemiologists, of course none of the well-trained ones at the University of Texas, look at racial and ethnic categories and then don't look beyond them to see what behaviors actually underlie these categories and whether it actually is related to race or ethnicity or whether that's just a convenient label. So I'd like you to think about that as we go through this. Then I'm going to be talking about 2 or 3 very new studies in the area of drug use and drug risks in the border region, studies from the last 2 years, not my studies, but studies in which some people in this room have been involved, and then try and reach some conclusions or perhaps simply ask additional questions. To try and put the region into worldwide context, if we look at the population prevalence of HIV, we find, as I'm sure you know, that sub-Saharan Africa has by far the highest prevalence, followed by the Caribbean. So right on our doorstep here, we have a region of the 2nd highest prevalence of HIV in the population. And then Latin America and North America come about 4th equal. So we're not at the stage of some countries, but parts of the region are headed there. When you look at the Latin American region as a whole, with regard to HIV prevalence and AIDS mortality, you find there are some characteristics of countries which stand out for high prevalence. Those countries with a low gross national product, greater income disparity, what we would call the Gini coefficient, low healthcare budget and few doctors, low contraceptive rate, and low antiretroviral therapy rates are all those which, not surprisingly, have problems with high rates of HIV prevalence and mortality. When we look at the evolution of the epidemic in the Latin American region and the Caribbean region, we find that HIV infection was initially associated with tourism, business travel, and migration. And it actually came in as essentially a, one might even call it an upper middle class disease, because it was the people who traveled who spread this disease and people had contact with them. And initially it was areas most dependent on tourism that had the highest rates back in the 1980s in the region. And the best predictors of HIV back there in the first decade, which a few of us still remember, was contact with foreigners and history of STD. But what you'll probably know is that disease sediments in society, by which I mean, using the analogy of something like an erythrocyte sedimentation rate, once a disease arrives in a society, it sediments to the point where it's the people who are most disadvantaged who have the highest rates of disease. And I think that was pointed out very well by Dr. Anders in his introduction. And quite often in this region, that tends to be people with a Hispanic background. But I think we need to be very careful that we distinguish between social class issues and cultural issues here, because the two are quite often conflated. And the other point I'd like to make is that there are a couple of subtypes of HIV prevalent in the Latin American region, mostly subtype B, but there's been a relatively new introduction of subtype F, which is commonly seen, I think, in Central Africa, into Uruguay and Argentina and Brazil. And they tend at this stage to be infecting different networks, which shows how there is always reintroduction of different strains or subspecies, and they follow the lines of social networks. You probably can't read this. It's more of an aid to me than it is, I think, to you. That's the United States. You can probably see that much. And what I want to do is just show you in the border region the rates of HIV per 100,000 population. California is way up there with over 200. Then once you get into the middle region of the border, you've got 98 in Arizona, about 96 in New Mexico. We go up again to 177 in Texas. But the other things you might like to note, in the small print is Puerto Rico, which has a rate of 334 per 100,000, one of the highest in the US, primarily a Latino population. So there are some issues, and you can also see Florida up there above 300. And the issues are numerous in Hispanic populations, but primarily men who have sex with men being at higher risk in Hispanic than non-Hispanic populations, and some issues of injecting drug use. CDC data, very interesting data. I'm always fascinated when epidemiologists break the population up like this, because for me, as somebody who's worked in the field of behavioral and cultural epidemiology, I would regard most of the Hispanic population in the US as white. So we have to be very careful about distinguishing between race, that is black or white, and ethnicity, which generally is Hispanic, non-Hispanic, and which we should, as has been pointed out before me, break down into subcultures with different colonial histories and regional differences. But for women with HIV, you can see that the proportion of Latinas is roughly equivalent to the proportion in the population, also about 15%. But that the figures in the US are very disproportionately weighted towards African American women, and that clearly affects how the percentage pie is broken down. But the question I'm still not sure of is whether Hispanic women who are also black actually fall into this category here or this category here. So you can, I think, begin to see the questions I'm asking about how we define these categories. In the CDC website, you'll find these key facts on HIV/AIDS with regard to Hispanics. First, that it was the fourth leading cause of death among Hispanic or Latino men and women aged 35 to 44. Second, that the proportion of the population and new infections is roughly where you would expect it to be. However, it seems to be increasing somewhat in 2006. It's up to nearly 20% of new AIDS diagnoses in people living with AIDS. And finally, that injection drug use, STDs, poverty, and cultural beliefs are some of the prevention challenges facing the Latino community. Now, what do we mean by cultural beliefs? And this really is at the heart of one of the questions I want you to think about when you leave this talk today. The issue of cultural beliefs can cover not only behavioral epidemiology and questions of ethnicity, but we have to ask the question, what is it about being Hispanic that puts people at risk in terms of their behavior? Are there any uniquely Hispanic cultural beliefs? There are some candidates, for example, language-related issues. The first way we often define whether somebody is Hispanic or not is whether they speak Spanish. That in itself is not necessarily a risk, assuming that health education is available in Spanish as well as English. There's an interesting hypothesis, though, called the Sapir-Whorf hypothesis. You've probably heard of it because it's the one which points out that Eskimos have 7 different words for snow and people living on the equator have no words for snow. So what occurs in a language often determines how people think about things and what concepts they have. And so it could well be that the Spanish language elaborates some words and doesn't elaborate other words, which might have implications for the way people think about things, including HIV prevention. The second candidate, and you'll notice these are all questions. I have, in fact, a number of question marks here. The concept of machismo and gender double standards, which in my opinion are not typical to Hispanic populations, but one can find in many areas across the world, the Middle East, the Indo-Pak subcontinent, Asia, even probably not far from Houston. There is the suggestion that commercial sex worker use is more of a norm, at least with older Latinos, than it is with non-Latino populations, which could be a risk factor. And then Latino conceptions of what homosexual behavior is, which I'm going to go into in a minute. And there may be others which you can think of. But I think we really have to ask, are these uniquely Hispanic? When we start looking at Mexico, it's a convenient microcosm of the region because as the 3rd largest country in terms of population in the region and with over 100 million population, you can actually cover the whole range of cultural and social conditions within the 32 states and the Federal District of Mexico. And what we know of the most recent data on AIDS cases is that they are overwhelmingly male. There is a fairly tiny figure of children under 15 and a few unknowns. But the thing that really stands out is this male-female ratio. And any time an epidemiologist sees a ratio like this, which is disproportionately weighted towards men, you almost automatically know that this is telling you that men who have sex with men are a big issue here. Because when you might look at, for example, a Central African population, you'll find the sex ratio is approximately equal, primarily heterosexual transmission. And this is a particularly high one, which tells us that men who have sex with men are still a big issue. Although, of course, these cases did start from 1983, which somewhat biases it. We find that most transmission in Mexico is sexual, 95%, and a significant proportion is homosexual or bisexual, probably half of that combined, homosexual and bisexual referring to men. There's some tiny residual blood transmission from the 1980s, cases still around. But what is misleading is this figure on injecting drug users. And what I'm going to show you is that this is extremely biased depending on where you are in Mexico and particularly for the border region. These national figures actually don't tell you what's going on closer to home. if we look at the prevalence of HIV by risk, by breaking it down by actual behavior, by actual findings from surveys, we find that, again, it's confirmed that the prevalence, note I'm talking now about prevalence in a population, the one that really stands out is men who have sex with men. About 13% of that population group, based on population estimates, is already infected with HIV. And then men who have sex with men, commercial sex workers. So men and commercial men are at high risk. And then we go down to commercial sex worker female injecting drug users primarily, and so on down the list, down to a fairly respectable figure for pregnant women. And there have been some new developments in the last couple of years. The first in Mexico is that nearly 2,000 cases were identified in the indigenous population. That is, in cities with more than 70% indigenous population, and a high proportion compared with the Mexican average is in women. So it seems there's an emerging epidemic in the indigenous populations. When we look at the Mexican situation by state, it's probably no surprise that the federal district, with one of the largest cities in the world, was disproportionately and early affected with HIV. The other surprise, though, is Veracruz. But I think this is probably because it's a port city and it's actually Mexico's main window on the Caribbean. And remember that I showed you the Caribbean had one of the highest rates in the world. And so my suspicion, based on a semi-educated guess and very little data, is that it's this window on the Caribbean which makes Veracruz stand out. But it's the other window, the window on the US, which stands out, which is the San Diego-Tijuana metroplex. And you can see other large cities are represented, including our own local situation here, the El Paso Juarez twin city situation. So when we look at the most exposed sectors in Mexico, male sex workers in Mexico City and Guadalajara top the list, but we have Acapulco and Monterrey close behind, again the tourist influence. Then male injecting drug users in Tijuana, female injecting drug users in Tijuana, and then we have another very high figure with injecting drug users just over the way in Juarez. If we want to see whether what we have on people on the United States side of the border, we can look at a very recent survey of people with HIV and AIDS. And of this sample, they follow very much the Mexican data, with a largely male sample, as one might expect, largely Hispanic, a significant number self-identifying as gay, and with their exposures being with other men, so between a quarter and a third heterosexual exposure, and some higher injecting exposure than you would see in the rest of Mexico. So clearly what happens on the border is a special case with regard to what happens in Mexico, and I would argue probably a special case with regard to what happens in the US. And of the sample of people with HIV and AIDS on the US side, 15% were farm laborers, nearly half were on public income or unemployed, so we're talking about the disease here sedimenting again in society. But I also think we need to look at what the concept of a border is. And of these people who were already infected, their median number of border crossings per year was 5. And so we're talking about, with regard to disease, a very porous border. I know most people in the US tend to think of borders as being a one-way traffic, of course not helped by certain politicians who are mercifully not with us anymore. But the other thing I want you to take away, and I'm going to talk about in a minute, is what exactly is a border, because I think it's a two-way traffic. And we know what's transmitted south to north, but we need to start asking, as behavioral epidemiologists, what's transmitted from north to south? And the final point is that this was a population of whom a third spoke only Spanish, so we have access issues with regard to health care in terms of language. If we're looking at HIV in the USA, we find a somewhat different pattern, and what I'd like you to really focus on is the fact that injection drug use is a big risk in the US and is really only appearing in the border regions. That is literally along the border with regard to the Mexican population. And within the US, we find pretty similar rates of infection through IDU use with males and females. However, it is the fact that in the United States and in Mexico, most infections to date are through men who have sex with men, or MSMs, we call them in the US, HSHs in Mexico, men who have sex with men. The first issue I'd like to emphasize is Joe Carrier's work on Latino definitions of homosexual. And the issue that Carrier has noted since his beautiful work in the 70s is that what is considered homosexual in Latino culture is defined not by who the sex act is with, that is whether it's with a male or a female, but by whether the act is insertive or receptive. In other words, it's defined by genderizing the act into an active or a passive, if you want. And so if a man has sex with another man, but that man is the insertive partner, then he's not a homosexual. He's just a heterosexual man playing the field. And so when you use the term homosexual in a Latino culture, it's more likely to mean the receptive partner rather than somebody who's having sex with men. And because so much of our early education was based on using the term homosexual or gay, that led a lot of men to think that if they were the insertive partner, they weren't particularly at risk. The second thing I'd like to mention is the equally elegant work of Rafael Diaz in San Francisco. And he wrote a book on men who have sex with men, Latino men who have sex with men. And the issues he found were first that they saw themselves as being highly stigmatized in the Latino population and Hispanic population as being failed men, that's his term, because they're gay. They've let down their family, they're taking a gender position that's associated with lack of power and with being a woman. The second issue he noted was that of sexual silence and lack of social support, that the issue of men who have sex with men is just not talked about, at least by the families of many of his men in California. And the sense of ignorance and isolation that men who have sex with men face, even in San Francisco, which one might argue is probably more attuned to gay issues than most other cities. There's the work that Simon Rosser and I did with our Latino men who have sex with men internet study. And men who have sex with men, and of course many other issues, have come into the 21st century on the internet. We actually found that Latino men didn't have a higher risk than non-Latino white men on the internet, that men had more partners that they got on the internet, but they had a lower risk compared with partners they found in conventional places like bars and clubs. So it kind of averaged out. And finally, a recent study by Theo Sandfort in New York, where he identified huge problems with internalized homonegativity, what we would call homophobia, in men who have sex with men. And Simon Rosser and I also found this in our Latino internet study. The issue of men feeling so negative about themselves about being gay that they didn't take precautions. Rafael Diaz's work has led to a rather beautiful intervention, Hermanos de Luna y Sol, which is the name that gay men give to each other, at least in California, brothers of moon and sun. It almost sounds like an expression that St. Francis of Assisi could have used 800 years ago. And their intervention aims to reduce low self-esteem, to reduce the perceptions of low sexual control, about the inevitability of HIV infection, and the lack of family and social support, which have been identified as key issues for Latino men who have sex with men. If you go to the internet and put in the keyword, you can actually find the program at the University of California, San Francisco site. So there are very specific cultural issues with regard to men who have sex with men in Latino society, but I would argue from the work I've done in India that these issues are not primarily Latino. I could describe those issues as occurring in India or in parts of South Asia as well. So again, the question is what is truly Hispanic and what is a function of other cultural issues? Well, I want to share with you a few studies that have produced some fairly new data on injecting drug use, which seems to be an issue along the US-Mexican border, more of an issue than you would like it to be with the problems in Juarez at the moment. And these are the first data that Jane Maxwell at University of Texas at Austin has provided. And she found in all of the Texas border counties, in terms of the risk factors for AIDS, that in Texas it was about 8 or 9% injection drug use, a high proportion of men who have sex with men and injection drug use, and again, men who have sex with men, very similar to San Diego at the other end of the border, although the injection drug use was slightly higher. So on the border, it's a huge men who have sex with men issue north of the border, and injection drug use is up there. When we look at case rates for AIDS, however, we find that there's a gradient from San Diego coming down to, and I mean coming down geographically, not in any other or moral sense, to Texas. You can see that San Diego has the highest rates, and they tend to come down again. You get a bit of a blip around the Arizona border, around Tucson, Pima. You get another little bit of a blip in El Paso, Juarez, and then these are the highest Texas counties. So it looks like there is an AIDS gradient along the border, starting at San Diego, blipping again in the middle, and then another little bit of a blip down towards Brownsville. So we have a trimodal distribution. And we see this reflected, as one might expect, in the Mexican border state AIDS rates as well. With Tijuana up there, we get the El Paso Juarez blip, and then fairly steady rates through the rest of Texas. And these are of course, rates per 100,000. So what happens north and south of the border and along the border is quite different to what seems to be happening in the rest of Mexico. Part of this can be explained by migration and movement risks. Migration we think of as mostly being northward, but I'm sure everybody here has at some stage sat in a traffic jam on the bridge on the way out of Juarez. And you know that there is a lot of what I call micro-migration of people who are not disadvantaged or illegal immigrants going to and from, whether it's for work or to visit restaurants or to visit friends or to visit sexual partners or to go to parties or whatever. And so when you're talking about an infectious disease, it may actually be this micro-migration which is determining this more than the migration of educationally and economically disadvantaged populations. And the interesting thing about this micro-migration is it imports back into Mexico a lot of what happens behaviorally in the United States. And again, as we know, within the 100-kilometer border zone, there's a huge amount of non-migrant travel. Juarez, El Paso, the last figure I got was 30 million crossings a year. So let's start thinking about the behaviors that are imported back, as well as from north to south, as well as the drugs that are imported from south to north. And as a behavioral epidemiologist, I'm particularly interested in how those behaviors influence risks on the southern side of the border. And many migrants are no longer rural, but often break their journey in the border cities. 60% of the Juarez population came from outside of Juarez, and over a third from outside of Chihuahua. There's been a lot of focus when we talk about Hispanic populations in the US on migrant farm workers and undocumented migrants. I don't think those really constitute a particularly high HIV risk until they go home. And a study on migrant farm workers showed that about 10% report sex with other men. Interestingly, about the same proportion receive money for sex with other men. There's a fairly high use of illegal drugs, although a lot of that is marijuana. I'm old enough to come from that generation where marijuana was considered normative rather than illegal. Of course, that was before I came to the United States. About a fifth of that is cocaine. Note that these two diseases often serve as markers for risk, chlamydia for sexually unprotected encounters and hepatitis C for injecting. And the other issue which really stands out for me, which I think has received insufficient attention, is that 20% reported therapeutic injections, that is injections of antibiotics or vitamins. And frequently, needles and syringes were not sterile or had been reused. And there's now some evidence coming out of Africa that in some places, such as Zambia and Kenya, there may be a higher risk for these non-medical, but nevertheless supposedly therapeutic injections. And given that migrants are usually male separated from their families, then commercial sex workers figure fairly largely. If we look at people who define themselves as Hispanic in the United States and had HIV, this is a sample of people with HIV, what are the differences between US-born and Mexican-born Hispanics? Well, you can see they're pretty big. And so I'm suggesting that one of the risk factors is actually not being Hispanic. It depends on where you were born and socialized and the risks where you come from. Much higher injection of drugs amongst US-born Hispanics. Somewhat higher men who have sex with men exposure. Reversed proportion with regard to heterosexual exposure. Remember, these are people with HIV. And the other huge difference is the injection drug use figure. Ever or as a risk factor. So clearly, and this is confirmed in a study on the Texas border, clearly being born in the US predisposes you to injecting drug use if you're a Hispanic. And this is one of the behaviors I'm talking about that might be, how shall we say, re-imported back into Mexico, which is why we have different rates on the borders, and particularly with injecting drug use. And the Texas Border Drug Survey, interesting figures, but what I'd like you to particularly focus on is this last point, that the percentage of risk of HIV through injecting really has a very high socioeconomic gradient, and also a very high geographic gradient, because the further you get towards the middle of the United States and Mexico, the higher the rates become, and amongst the very disadvantaged, the rates are particularly high indeed. So disadvantage is also standing out as a risk factor here. But I don't think this disadvantage necessarily has anything to do with being Hispanic, although if you just looked at ethnicity, you might think that. First, there are different patterns of injecting and sharing, depending on what is being injected and shared. Some drugs may give you a risk because of injecting, but some may also give you a risk not because they're injected, but because they function functionally as aphrodisiacs. Crystal methamphetamine, known as ice, and I use the term ice because it takes up less spaces in my slides, was frequently used as a party drug by men who have sex with men in the West Coast, California, and then spread to the rest of the population. You might consider men who have sex with men as being early adopters in this regard. And has a very strong HIV-STD association, not necessarily because it's injected, it's usually not, but because it's used to keep people partying for sort of sexual marathon sessions, and is taken before to facilitate long sexual sessions, or to actually counter the effects of heroin. I tend to think of drugs as being drugs for getting into it and drugs for getting out of it. The drugs that actually send one into an altered state and off to sleep, and the drugs that actually focus attention. And if one is taking heroin, for example, which is a drug for getting out of it, and wants to have sex, then you need a drug for getting into it, such as ice to counter that. And then crack is the other one, because there is a high level of sexual disinhibition and it has a fairly short half-life. So people need to repeat every few hour or few hours. And there are frequently women in the crack house culture who are there to provide sexual services in return for drug or money. And crack also has a high HIV-STD association. So let's not think that injecting is necessarily the risk. I would argue that it depends on the drug and the reason the drug is taken, and there are some inhaled or smoked drugs which are equally risky in terms of their association. Just briefly, some data from Jane Maxwell's study where she looked at admission rates for drug treatment. And she found basically that while there are some differences in the way drugs were consumed, going to smoking from inhaling with methamphetamine, that the primary drugs for admission were pretty much the same on the north side of the border. But when she looked at the Mexican data, which only became available a few years ago, she found that there was a huge spike in admission rates for people who had the problem of methamphetamine addiction. That is, smoked. Almost nobody injects methamphetamines unless they're desperate. And this is actually a key slide, because what Maxwell found was that there was a difference across the border by drug. That on the Pacific coast in San Diego and Tijuana that methamphetamine was the dominant drug. Here in El Paso and Juarez, heroin was the main drug of concern and presence. And then when you get down to the Gulf end of Texas and Mexico, you find that cocaine is the main drug. And so you have a very different geographical pattern of drugs and therefore risks as you move from Pacific to Gulf Coast. So let's not think that there is anything inherent about drugs on the border, because the drugs are very different depending on where you go. And this pattern, she says, was influenced by trafficking, that methamphetamines trafficked primarily to California, heroin, middle border, California, and cocaine all along. My suspicion is that this may not simply be a matter of trafficking, because trafficking follows where demand is. So this is very much a chicken and egg situation. Is it the trafficking that causes it, or is it the demand that's fueling it on the border? I think just before I go on to the next slide, I would have to suggest that one of the problems in trafficking, though, is that along the way, drug is decanted for payment. Decanting is actually the term my Indian colleagues use, in India, I mean, for what happens to funds from outside the country as they kind of go down the level. Everybody decants a little bit until the recipient only gets about 5 or 10% of the money. And you get a similar decanting by payment, so that if people are trafficking drugs across the border, they will get payment in that type of drug. And therefore it may be that this is actually fueling the different types of drug along the border. Again, we don't know the actual cause yet. The other point I'd like to make is that there are very gendered patterns of drug use, in addition to geographical ones. In methamphetamine admissions, much higher female rates, possibly because more women use amphetamines and related substances for weight loss. There are gender differences in the border programs for cocaine admissions, but heroin tends to be a more male-oriented drug. Now, just briefly, a couple of other studies before I summarize and let you ask questions. A recent study just published by Cruz and colleagues, done in Juarez and Tijuana, note that an earlier study by Patterson found that 3/4 of female sex workers in Juarez had ever injected a drug. This is an astonishingly high figure. I think it speaks to where the epidemic is on the border here. And it was up from 10% in 1992. And only 1/4 had in Tijuana, for reasons not fully understood. But she notes there were very different gendered approaches in this qualitative study to female sex workers. First, that females obtain drugs through purchase locally, whereas men tend to go all over the city and get them in non-local areas more predominantly. Second, women tended to use the drugs at home, whereas men would likely use them in shooting galleries. For women, the relationship dynamics meant they usually injected with their partner and used the needle and syringe after their partner, which was a very clear risk. And for half the women, there was clear sex trade involvement, and men also noted the high level of commercial sex workers around shooting galleries where they could actually get the drug in return for sexual services rendered. And another very recent study just came out a few months ago by Stephanie Strathy and colleagues, again in Juarez and Tijuana. Just look at these hepatitis C rates and hepatitis B rates in Juarez. They are just astronomical. I think they're among the highest I've seen in the world in injecting drug users. There is clearly going to be a huge problem in the future with liver failure if they get that far. It was quite a big study of female sex workers, nearly 1,000. And comparing drug-injecting female sex workers, they were more likely, compared with non-drug injecting sex workers, to be street workers, which means pickups on the street are kind of lower class. We tend to class sex workers by escorts at the top, brothel workers around the middle, and street workers down the bottom end, and there is a price gradient that goes with it, and also level of control that goes with it. So there are class issues even there. Many of them speak English, and that is relevant because this is one of the behaviors where border crossing is relevant here, that people may well go into Juarez for sex partners, not just because the medical treatment is cheaper, although that may be relevant for STDs. So this is a concern. Their partners, their clients may be from north of the border. They tend to have worked longer in the sex trade, be married, to have lived in the city longer, to earn less for sex with a condom, and often or always use drugs before sex. So there's a clear bridge population here, and I'm not necessarily, well, maybe that is a pun, maybe I am referring to the international bridge as well. So what can we note with regard to these issues? The drug patterns differ strongly from east to west, and there are minimal drug pattern differences from north to south. That is, the twin cities from, from north to south tend to have very similar drug use patterns and risks. And I would argue that is probably because of what I suspect is this north-south difference in risk behavior, of behavioral trends that occur north of the border and are transferred south, whether they're injecting or whether it's travel for sex partners. The endpoint for trafficking is not actually the border, it's the large cities inside the US, like Dallas and Houston and Los Angeles and places north. But it may actually be payment in drugs. One might call that micro-trafficking, which is the issue on the border. And hence the north-south similarities. And so we have both east-west and north-south differences, not only in drug gradients, but also in terms of what is transmitted in both directions. Drugs going north and risk behaviors going south, maybe, or at least trends in risk behaviors. So, in conclusion, remember at the beginning I asked, what is there actually about, not about identifying oneself as Hispanic, but about actual risk behaviors from a behavioral epidemiology point, which puts people at risk with regard to HIV/AIDS. I think we have to consider that epidemics come in different waves, and the wave of injecting, which is now reaching into Mexico through the border cities, is actually just the epidemic arriving later than it has in the US. I think the place of where risks occur, whether it's the east or west, depending on the drug used, or urban or rural, is probably another risk factor. And you'll notice I go down this list that there are almost none which I would describe as specifically Hispanic. There are particular drugs which give rise to particular risk behaviors, whether it's crack and crystal meth, giving rise to heightened sexual behavior, or the injecting behaviors of heroin and maybe cocaine. There may be issues of the drug routes and using the drug as payment in here. The risk depends on what drug is going through and what the payment is being received in. Power, gender, and economics, I think, can probably not be separated. Who gets to use the needle and syringe second or third or fourth? Whether the female partner has a choice in using a condom. Whether the female partner has power at all, as we saw was a risk for domestic violence in the previous presentation. And economics. When people need money, they do things and don't think about the consequences. 8 years down the track. If a woman is wanting to feed her children today and the question is whether she'll get HIV and get AIDS 8 years down the track, then the children usually come first. Or if she's hanging out for drugs, then the issue is the drugs. The whole issue of immigration and class is so tied up that I don't think it's a Hispanic issue at all. I think it's an issue of differences in economics. And when you have a poor community to the south and a rich community to the north, you know, we're not supposed to talk about class issues in the United States. I had the opportunity to study in England, where class issues are much more to the fore, and we don't mind talking about them. But here we pretend it's not an issue, and we start using labels like African American, Hispanic. And what I would argue is what we're probably picking up is class and socioeconomic issues here, the two being pretty synonymous in the US. And finally, prevention messages may not be equally well transmitted in Spanish and in English, or even equally funded. When people talk about sexual risk behavior and Hispanic populations, often the first question I get is the question is, well, you know, they're all Catholics, usually Protestants saying that. As a Catholic myself, I can say that there is huge variation on attitudes, and particularly since we're on the 40th anniversary of that very unfortunate encyclical Humanae Vitae about contraception. Most of the Catholics I know are what I would call Pelosi Catholics. Pelosi Catholics, I know it sounds like a wonderful heresy from the Middle Ages, but for whom this is a dead letter. So I don't think we can just attribute changes or differences in Hispanics and non-Hispanics to religious issues. The issue of male, I'm not sure that language, provided services are equally given in terms of prevention, is necessarily a language issue, but I'm prepared to admit that it may be a particularly Hispanic issue when we're talking about the Spanish language. And then finally, I'd like to think of borders as being a two-way concept, whether we're talking about east-west, east, middle, and west differences, or whether we're talking about north-south differences. They are two-way processes, and we need to think about what is transmitted in both directions. Of course, we know about the drugs going south to north, but I think we should, at least those of us who are behavioral epidemiologists, think about what's being transmitted north to south in those 30 million border crossings between Juarez and El Paso a year. So I think I've probably just about filled the time available, and you probably all want your lunch, and I'm quite happy to answer questions at lunchtime, since I know Dr. Anders probably wants us to finish on time. But if you have a couple of questions, I'm allowed to take them. No, it looks like lunch is one. Oh, we have one down here. Yeah.
I just am curious about market forces in the drug world. So it seems to me there's some areas where there's not a lot of cocaine, there's a lot of crystal meth, and those, to me, I would think would also be market issues for people who are selling this drug. So you would find areas that might hold out against the new drug, or areas where drugs come in. Is that something that you...
Yes, and I think they're markets for a lot more than drug. We find, for example, the concentration of female sex workers around the two drug endpoints of Tijuana and Juarez to be particularly high, because they're taking advantage of the opportunity to trade sex and drugs. I think the entire drug trade is based on that principle of economics, that it's a supply and demand issue, even though the US government seems to think only about the supply issue when they're talking about this. But when you get micro migration across the border, you get really small, that is probably commercially fairly negligible amounts of drug going backwards and forwards from Juarez primarily to El Paso. But you also get the behaviors associated with them being transmitted back across the border, and this is a guess. And so there's also a market for innovation and new experiences and better ways of making use of the drug, which are more efficient in terms of, well, you know, you could literally call it bang for your buck. Yeah.
Have you come across, through your work and others' research, how much also of it plays into the forced sex slave market that's increasing right now with the human trafficking numbers, and how that's playing a role in HIV and AIDS, the spread of AIDS?
Not specifically, because I like to think of force as being not a binary, but as a gradation. And I think even in domestic violence, there was the concept that there might be different levels of violence, whether it's whether it's psychological violence and pressure, or whether it's actual physical violence. The fact is, if a woman doesn't have a choice, or for that matter, if a male sex worker doesn't have a choice, then that is, to some extent, a level of slavery, even though it might not reach the level of somebody being actually physically abducted and sold. So I would much rather like to think about it as levels of lack of control, but the short answer is yes, it's an issue, and no, I don't know much about it.
Thank you, Dr. Rock.
Okay.
I'm just going to.
Oh, Joe.
Sorry, there's one area I just want to comment on because I think we do very little about it in this hemisphere, and that is the issue of these therapeutic injections.
Mm-hmm.
This is a huge issue. It's not. When we were in Pakistan, we were investigating an outbreak of hepatitis. It turned out to be terminal hepatitis C. And to make a long story short, what we found was that in the country, the overall prevalence was 7%.
Yeah.
And almost all of it, with some careful epidemiologic studies, is associated with therapeutic injections. And this is the point I want to make about Europe here is we found out that people, when they went to curanderos or hakims, as they were called there, expected to get an injection because it was considered to be stronger. And the curanderos could charge more money because instead of giving an oral, they could give an injection and make more money.
Well, you could call it, instead of giving an oral, giving an anal.
That's
perhaps.
right.
These two.
This sort of economic synergism that was incredibly powerful, and virtually the entire epidemic of hepatitis C, which is enormous in Pakistan, is because of that phenomenon.
I couldn't agree more. I think this is the one of the missing links in our approach to HIV, and my own experience in East Africa suggests, even though I didn't initially believe Potterat and Giselquist that this was an issue, I've looked at the data and come to realize this may be a huge issue. And it's the one that almost never appears on anyone's radar.